Okay, we ready? Okay, my name is Maureen Craver, and I am happy to introduce Colleen Wasemann. She's been working with our son Jack since he was, I don't know, like 2 months old, probably. He'll be 6 in September, so we have a really long working relationship. Colleen is a doctor of occupational therapy, has been a pediatric occupational therapist for 25 years, working with families and their children during the mealtime process. Colleen is the co-owner of Feeding Friends since 2007. Feeding Friends is located in Noblesville, Indiana, so just not too far from here. She provides early intervention and clinic-based services to help children birth to 18. She's an adjunct faculty member at the University of Indianapolis School of Occupational Therapy.
Hi. First, I always like to check, can everybody hear me okay? Okay, my voice tends to drop the longer that I talk. So if in the back, if you cannot hear me, just wave at me. So let me know. I also get to play the great glasses game while I talk to you because I'm now over 50. And so I can see all of you are super blurry. I can see none of you at all, but I can see my computer screen really well. So I get to play the great glasses game. So of up and down, up and down. So I'll probably do that during part of our session today. So, which also tends to make me lose my place of where I'm talking. So, you know, that doesn't help matters at all. So, my name is Colleen Wasemann, as Maureen said, and I do get the lovely pleasure, I should say, of spending my weeks with Mr. Jack, who is a phenomenal kid. So I hope you guys get to meet him someday. But I am a pediatric occupational therapist and co-owner of Feeding Friends. I've been an OT for 25 years, specializing, like I said, or like Maureen said, in pediatric feeding disorders, but my love is really infant feeding and G-tube weaning. Those are my two favorite things. And then also working on sensory-based feeding disorders. I've done a little bit of research here and there, and most of the research that I've been a part of is really focusing on parent confidence and stress during the mealtime process. And I feel like every time I turn right, my voice drops. Is that correct? Do I need to adjust this? You guys are good. Okay, perfect. So today what we are going to do is we're going to examine the global view of feeding, which was developed by myself and one of my colleagues, Jennifer Milton. She has an earned degree in Master's of Science in Behavioral Analysis, and she's also a developmental therapist for our agency, providing early intervention care. So we're going to discuss, or I will discuss today, how each factor of the global view of feeding plays a role in the mealtime process. We're going to discuss what you as a parent, or as well as your child's therapist, might see clinically, what general therapeutic strategies might be used, take a brief view of a case study of Mr. Jack, and leave times for questions, and hopefully I have some answers for you. So we'll see how that goes. So I provide this training to parents who are part of our agency's community partners, as well as to graduate students who are pursuing a career in occupational therapy. And we just find at our clinic that the use of this global view of feeding helps parents as well as new therapists organize their thoughts and maybe even determine like the next steps for feeding, next steps when looking at their child's current mealtimes. Given the time of the session and that our bellies are full, I think you guys just had lunch, and I do see lovely pastries out, so that's joyful. I am an OT, so when I teach and when I'm working with my students are up and they're moving and they're standing because our bodies really are not made to sit for a really long period of time. So if you feel the need to stand or to rock or to sit different ways on the chair, I do not care. So it doesn't bother me. You're not going to disturb me. So please get up and move your body because, again, that's not really kind of how we're meant to move. So moving on. So the global view of feeding examines what we have determined as 5 different factors of mealtime. So just that we're all on the same page, when we talk about mealtime, we are talking about any time that the food enters the belly. So we're talking about whether that's orally, whether that's through a tube, or whether that's through a combination of both. All of that is considered to be mealtime. Our factors include medical, or how our body systems impact mealtime, oral motor development, or how our mouths coordinate the safe consumption of foods and liquids, oral sensory development, or how our body interprets the sensory properties of food, child factors, which examines not only the child's response to mealtime, but their sensory response to food, their overall sensory development, their visual skill development, their overall motor development, and processing, cognition, and language skills. So really, when we're looking at the child for mealtime, we need to look way beyond what's happening in the mouth and way beyond what's happening from an oral sensory standpoint, because all of development can really impact mealtime. The final factor is our parent factors, or what we as parents, caregivers, and therapists bring to the table. It's the interplay of these factors, and that's why we put it in a circle, right? Because one factor leads to the other, which leads to the other, and then zooms across and leads to this and leads to that. So, but all of that interplay of these factors make up the mealtime process. And we use the knowledge gained when examining these factors to determine a game plan or a therapy plan to assist the child and family in the mealtime process. So as you listen today, you may find one factor that really pops out at you and you're like, man, I need to take a longer look at this with my kiddos' mealtime process or with my kiddos' mealtime. Some of you may find that all the factors are contributing, and that's okay too, because we're not made to work on everything all at once. We do best when we kind of hone in and we work on one thing at a time. So it really can just help us triage what's the most important and what's the least important for that day. So our medical factors include our birth history, our current medical history, any past or upcoming surgeries, and any other pertinent medical information that would impact the child. We take a thorough history during the initial evaluation and then continue to monitor the health status of our clients. As parents and therapists discuss the medical status of the child, together we can provide insight on how the body systems are impacting the child in real time, or clinically what we see during meal times. While all body systems are important in our clinic, likely due to the impact of prematurity, children impacted by a genetic condition, likely due to undetermined cause for feeding disorders, or just due to a general restricted diet, gastrointestinal issues appear to be one of the main reasons we receive a feeding referral. We are consistently providing care to children with concerns for dysphagia or GERD, projectile vomiting, constipation, and diarrhea. Of these, the biggest perpetrator is GERD, and I'm sure most of you could probably raise your hand to, yes, that is probably true. Sometimes, lovely, this is paired with projectile vomiting, right? So, and we see that. Some of my parents report projectile vomiting upwards of 5 to 8 times in a day. So after every single meal, or during any sort of change in position, or any sort of movement. So that's a lot, right? That's a lot of vomiting to happen in one day. So chronic digestive issues can lead to poor sleep, poor self-regulation, poor social engagement, and general irritability. I don't know any person who has any of these symptoms that wants to socialize, right? Or wants to sleep well, right? But yet we expect our kids who feel this way to still do all of those things. So that's just you can't tell I'm going to step a little bit on a soapbox. So, and then I'll step back off. So, but as a therapist, and I speak for other therapists that I work with as well, there's a level of frustration with the lack of urgency and ongoing attempts to normalize chronic vomiting in the children that we care for. So it is not normal to vomit that many times a day. So we have to really be good advocates to our GI doctors and our respiratory doctors and our cardiologists and our dietitians and our pediatricians and our developmental pediatricians to say this is not normal and we need to fight for better because it so impacts everything that child does. So, okay, off the soapbox and onto the topic. So we really think of vomiting as different than a normal sit-up that can be absorbed by a bib or a burp cloth. And what we have found in most cases, once those digestive issues are resolved and we can make headway. So with oral motor and oral sensory skill development. And when we talk about JAK, you're going to see what the difference was when that GI system was improved and was working well. Not that everything is better, but a lot better, right? Yeah. So we have a happier child and honestly, a happier parent who isn't cleaning the carpet, washing the car seat cover, or changing their own clothes multiple times in a day. While digestive issues tend to take the forefront, other medical factors that can impact feeding and eating include cardiac and respiratory issues. With respiratory issues, the body's number one goal is to breathe. So that is our downright, that's what we have to do. If we cannot coordinate our breathing, have an increased respiratory rate, or cannot seem to catch our breath, the ability to safely coordinate the suck, swallow, breathe synchrony can then lead to higher risk of aspiration. For babies that are awaiting cardiac surgery, the child's energy resources may be limited, which impacts their endurance to consume foods orally, or at least not in a volume that would support growth and nutrition. The use of enteral feedings may be used to support intake to ensure proper growth, ready the body for surgery, and take the pressure off of oral consumption. Again, this is just a really brief overview of the body systems that can impact feeding. And we could go on and talk about all of these other pieces, but we don't have all that time today. So we're just going to talk about the hot topics on that. So, but I really feel like it's our role as therapists, and I would encourage parents to really encourage your therapists to take an advocacy role with the health professionals that you are working with, so that we can present and report back what we are seeing clinically, so that all the individuals that are working with that child have a more complete picture of the child. Our second factor is oral motor factors. So we're examining with oral motor skill development. We want to know how the bones, the muscles, the nerves, and sensory responses are forming to support safe eating and swallowing. Is the jaw providing enough stability for the tongue to move laterally, elevate, protrude, retract? Tongue has to do all of those things in order to form a really good bolus. Is the tongue able to cup around the breast or bottle efficiently to transfer breast milk or formula into the baby's mouth? Are the lips able to maintain closure so food and liquid can stay within the mouth, clear spoon, and provide enough seal in order to drink from the breast, the bottle, or even a cup? Are the cheeks providing enough stability for bolus formation? Over time, we look at chew patterns in the mouth and how the child is responding to different textures. Is the child using a munch chew or a vertical chew pattern? Or are they able to demonstrate a rotary chew pattern? So that we need to use to break down complex or multiple textured foods into a bolus. Oral development can come from exposure to a developmental sequence of feeding opportunities, or it may be that we need to be more intentional about the development of these skills. It's important to start early to support natural oral curiosity or early oral learning, even when the child is not able to do so on their own. And as a therapist, that is my responsibility to coach the parent to work through those early pieces. How do we bring the baby's hands to their mouth? How do we get them to engage in a toy that we can explore orally? That's our job, to really coach the parents to do that piece. See, I lost my place. Where was that? So sorry. I'm glad you guys are chill. So that's really helpful for me. So this type of exposure, when we look at that oral sensory really early on, or the oral motor really early on, can not only prove the way that the mouth responds to food and liquid, but also can assist with decreasing oral sensitivity. The coordination of a child's chewing patterns, as well as their endurance during mealtime, can impact a child's food choices. Sometimes what we view as an oral sensory concern is actually a delay in mature oral skills or lack of coordination, not supporting food transitions. So often when I see infants come in, or 9, 10, 11, 12-month-olds come in, and they're stuck on purees because they can't move on to soft table foods or working towards dissolvable solids, there's an immediate assumption that's an oral sensory concern. When truly, when you look at the oral motor pattern, the child doesn't have the ability to put that food over to the side of their mouth, to really masticate down, to really use that vertical munch chew pattern. So again, what looks like an oral sensory component, because the child is gagging and vomiting in response to other foods beyond a puree, is really, we need to get the mouth moving right. And once we get the mouth moving well, some of that oral sensory issues just kind of dissipate on their own. So that's what I mean by that. We also like to think, of the workload of the meal when it comes to food presentation. So if foods are difficult to chew, or in general, chewing is effortful for the child, volume consumed can be impacted as a child doesn't have enough endurance to get through the meal. A good balance of this workload helps us to meet the child's skill level. So if I had to consume a whole plate of steak, and that was my only part of my meal for the whole meal, my mouth is going to be really tired. So because I chewed and chewed and chewed and chewed. But if I have steak and I have mashed potatoes, and I have soft green beans, and then I have something else that's maybe a little difficult to chew, I can balance that between all those different foods, give my mouth a rest while I'm still continuing to gain calories and fill my belly. So really looking at the workload of a meal can really help kids in terms of increasing that volume while we're still working on that oral motor skill development, coordination, and endurance. To address oral motor development, your therapist may encourage the use of non-food tools, such as like a chewy tube or an arc probe, or they may use food as tools to promote skill development. In our practice, we try to use food as much as we possibly can because we don't want to waste a calorie. So if we're going to work on chewing, let's work on something that we can chew. If we're going to work on lateral movement, let's work on something that we can chew, but also gain a few little calories here and there. So most of my kids that I see are, you know, in the first, second, third percentile. So we can really work towards adding in those extra calories. The therapist may also request a modified barium swallow study or a BFSS or a FEES to assess the safety of a swallow. Our second factor is oral sensory factors. So oral sensory processing includes the taste, texture, and temperature of foods. We could honestly name this factor the sensory response to mealtime, but we'll discuss this further when we talk about child factors. Children can demonstrate a typical response, a hypersensitive response, or a hyposensitive response to food properties. We might see hypersensitive children gag at the touch of food in their mouth. Hyposensitive children might overstuff to make sense of the food. Either way, children can become rigid in their acceptance of food by brands. The manufacturing process has done its job in keeping foods consistent, right? So I can eat a Snickers bar. I must be hungry because I'm talking about other food, but I eat a Snickers bar in New York and I can eat a Snickers bar in California, and they are exactly the same, right? That's the joy of manufacturing, or the good business of manufacturing. And our kids that we see that are really reluctant eaters, they bank on that, right? So, but rigidity is typically a response to the sensory processing system not processing the information well enough. A common strategy to address food acceptance is the use of food chaining, developed by Fraker and Walber, both speech-language pathologists. Food chaining is the breakdown of the properties of foods to chain to a new food that can be added to the child's diet. This process is a slow transition from one food to the next, allowing time for the child to also process and accept. As Fraker and Walbert say, we're always looking for new without a no. We also find that most of the children we see judge food by the presentation even before a bite enters their mouth. Our theory is that our children do not have a good visual memories of food and of their preferred food. I don't know about you, but I can picture my grandma Motz's vegetable beef soup at any point in time in the day. I know the smell, I know the taste, I know exactly what it looks like. So, and I haven't had her vegetable soup in probably about 15 years. So my husband makes a really good substitute. So he's working on mastering that. But like most of us, we can have a picture of some of our favorite food in our mind. However, children without a good visual memory or picture of the food may not have this capability and may rely on other characteristics to make sense of their food world. And we think about this from a behavioral component, but I'm going to challenge you to not think about it from a behavioral standpoint. I'm going to challenge you to think about it from a visual processing standpoint. So, because I personally, and maybe I'm crazy, but I personally think that kids that only want to eat food out of certain containers or only out of certain wrappers are because they don't understand if that food is safe or unsafe without that characteristic. They don't know how to process that piece. So we jokingly always call our kids food forgetters in the clinic. That, oh, you forgot what food you like, you're a food forgetter. But truly, I do honestly think they forget what they really like and what they don't like until that food has an opportunity to really become a good visual memory. So when I say Cheetos to some of my kids automatically know, oh yeah, that's that yellow puffy thing and I've got it. I know exactly what that is. But it's going to take them a minute to understand that and have that visual memory piece in their mind. And we're going to talk a little bit more about the visual system in just a little bit. So strategies that are really helpful to work on oral sensory processing are food play with a purpose. So, and I say that because food play is great. I love food play. I love sensory play. I'm an OT, right? So I love getting hands dirty and all that piece. But we need to have a purpose about it. It's not just about touching. We need to be talking about food characteristics during play, such as if it's cold or wet or dry or crunchy. We want to talk to children about what they see with their eyes, what they smell, what they might hear when taking a bite, or what it sounds like when you do, what they might taste, or maybe how that taste matches something else that they already like. So, and what they feel on their hands. And we call all these words our food vocabulary. So, and our food vocabulary is started really early with our kids. So we want to make connections to foods they know versus what foods that they don't know. So, and we find that if we start this really, really early, even our little babies, we use this same food vocabulary. When we're really starting to get into table foods, they already have an understanding. We'll talk later about developing receptive skills. We're building those receptive skills right there during that food vocabulary time. We can also find that visual presentation of the plate can make a big difference in coming to the table. So the picture on the left in the green plate is it overloaded? So, and to be honest with you, our son Henry, who was a phenomenal eater and could still out-eat most everybody at the table, that's totally what his plate would have looked like, and he would have been fine. So, but most of the kids that I see need the plate on the right. They need less on the plate. I can always add more. I can always add more. I can start with 2 pieces because I can still add more. So, and living by that rule really helps kids just kind of come to the plate a little bit happier and to the table a little bit happier. The 4th factor is our child factors. So, or maybe it's the 3rd. I lost track. So, a child's approach to meal, I think it's the 4th. A child's approach to mealtime can set the tone for the meal. It can be happy, the child can be happy or interested or curious, but also sad or mad. Parents and caregivers and therapists can feel collaborative with the child, or like I am heading into battle. So one of my friends, when she first started seeing me, the mom said to me, I really want to be able to feed my child in the wild, because and what she meant by that was, I want to be able to, when I'm out and about, stop at a restaurant or stop at a gas station and pick something up because we're on the road. But at that point in time, she was only eating out of a few different types of containers. And she sent me a message last night and she said, it's a feeding in the wild victory. She said the little girl ate an elephant ear at the 4-H fair last night and ate the whole thing. And I was like, that is that's a great choice for a feeding in the wild, is an elephant ear. But she made a really good opportunity of eating that. But yes, but that's what we look at from that, moving out of that battle piece to really being able to enjoy mealtime. So behaviors from the child are likely rooted in anxiety surrounding mealtime, and the behaviors can look like crying or acting silly. I have one little guy who likes to try to do flips while we're eating, and I'm like, let's sit back down. I'm throwing food. So defiance, I am not going to sit in that table today. There's no way. Redirection of the adult. I have one little friend that I work with right now. He's older, he's almost 12, and he likes to tell me his jokes of the day. Well, jokes of the day are about 10 in the session. So, and we're trying to curb him constantly to not be telling jokes, because if he's talking, he's got my attention redirected to something else or excessive talking. So to address these behaviors, we want to take note of other developmental pieces that contribute to mealtime. So we're going to talk a little bit more about sensory responses to food, visual skills, overall sensory skills, processing, cognition, and language skills, and motor skills. When the sensory system is either hypersensitive or hyposensitive, we can see differing results. Hyperactive responsiveness can lead to gagging. Gagging is very normal for kids when they are learning how to chew foods and when bolus management is still difficult. It's very normal. However, if gagging continues to happen and causes distress or leads to vomiting, then modification of the diet or assisting the child in managing bites can be warranted. This may be achieved by teaching children to take a drink, to wash down foods, distracting the child to bring their attention to something else during a gag, singing to your child, teaching your child to hum to provide vibratory input, or cold sensory information through a cold drink or a cold washcloth. The goal is to slow down the body and to get it out of that fight or flight response, because that gag is really a fight or flight response. So, or the crying or the throwing, they're just trying to get out of that piece. Another strategy that we use often is to work on deep breathing and counting, managing tactile information on the hands by providing the child with a cloth to clean their hands on their own. And now we've taught them how to self-regulate that piece. My hands are dirty, I don't have to do this. I can hand them a washcloth and they can start wiping off their hands on their own. Now I'm more independent and now I can take control of my own body. Sometimes we'll also work on circling the plate to encourage workload disbursement, as well as managing the demands that are placed on the kiddo. With hyposensitivity, we often see a lack of chewing foods to form a bolus, swallowing foods whole, or overstuffing of the mouth. So now you've got a kid with really big cheeks and they can't do anything. And while that's its concern, it stalls the meal. And honestly, it can be a really good behavior tactic, right? So, because if my mouth is really full, she's gonna ask me to put anything else. So we're, the meal's done, right? So at that point in time. So we really work hard on teaching kids to actively spit out the food if they're stuck, giving them an opportunity to try again. So, and it's no big deal. We just say, oh, looks like you're not managing that. Why don't you just take it out of your mouth and then we'll just try again. And we immediately move back into the next bite. So, but teaching children to advocate for what they need during mealtime gives them ownership of the meal. And they get to take on their own way that they want to consume foods. So we can modify those foods by smaller bites, teaching them how to place over their molars, or dipping into a familiar food. I had a friend yesterday that he was insistent upon dipping his chicken in chocolate. And I have a student right now, and the student was like, are you gonna let him? And I'm like, it's not my mouth. If he wants to try that, giddy up. So for him. So, but I'm not gonna eat it, but he loved it. So teach his own, right? So yeah. So this is the area that I really want to hone in on a little bit more when we talk about visual processing skills. And I really feel pretty strongly that this is an area that for feeding that we've not well, oh, there we go. It's not well studied or researched enough to really talk about in the mealtime process. So most of the kids that we see during at clinic or in early intervention have delays in fine motor and overall eye-hand coordination. Yet we don't always discuss this outside of self-feeding skills, like grasping a utensil and placing that utensil in their mouth. That's kind of where we talk about it. Can they take the fork? Can they find food? Can they poke it? So, or scoop it up with a spoon. However, our visual system begins with tracking of toys and the natural progression of visual acuity, or how well we can see. If a child improves in these areas, we're making assumptions that the child's vision skills have developed. However, we need to really take a deeper dive or dig a little bit deeper to look to see how is the child using their eyes in a more functional task, such as mealtime. And our first task that we look at is visual scanning. So can the child look all around the plate to see what is happening? So can they find that the yogurt is here and that the chips are here and that the sandwich is right in front of them? Or does the child have a field deficit and they're missing part of that plate? We may not know that, especially in a young toddler yet. So, or even a preschooler. So we talk about taking a plate tour. So to discuss all the foods that are on their plate. So we're doing a couple things there. We're building all that food vocabulary. We're also teaching them to scan and really understand what their plate is included. Another task that we look at is visual attention. So we need to be able to hold our visual attention on an object for a minimum of 4 seconds to process what we see and make sense of that. So I want everybody to pick something that's sitting in front of them. So, and I'm going to count, we're going to get ready, and I'm going to count to 4 once you have your eyes on it. And I don't want you to move your eyes away from the object. Everybody got an object? Okay, ready? 1, 2, 3, 4. That's a long time, right? It's a really long time. That was 4 seconds. I even said Mississippi's in my head. So I knew it was 4 seconds. So it's a lot longer than we think. And if we cannot sustain visual attention, we not only struggle with finding that object, but we also are also likely not able to make that into what we call a visual memory. So if we can't keep our eyes on it, that picture is not coming from the plate to our brain and sticking in there, right? So we need to really be able to process that piece. So as we discussed this before, our visual memory is the picture of something in our mind. The last development of the visual system is what we call visual cognition. So, and that piece is the piece that I think really impacts feeding and eating, because I think a lot of our kids don't have what we call good visual closure. So visual closure is the ability to see a portion of an object and know what that object is. So if I take an Oreo cookie, which, right, again, must be hungry, and I break it in half, my brain knows that's still an Oreo cookie, right? So if we take a chicken nugget and we break it in half on a child's plate before they see it, they may or may not understand that that's still the chicken nugget that they love, right? I don't think that a lot of our kids have good, what we call visual closure skills. So we talk about foods or kids becoming really upset when we break foods apart or things like that. I think it's because they don't recognize it. So I think we need to go back a step and show them the whole. This is what this is. Mommy's going to make it smaller for you so it's safer for you. Let's cut it together. So if we can do that, if that works for the kiddo and that works for the parent. But I do just think we just don't have really good visual closure skills. So, all right. Our sensory processing skills can impact mealtime beyond our oral sensory processing. And I know that you guys have talked a lot about, or have learned a lot, I'm sure, about tactile, auditory, vestibular, and proprioceptive input. So, and even olfactory. But there's one sense that it's not new, but it's becoming more enlightened in terms of the therapy world, or more highlighted in terms of the therapy world, is the better word. So, and that's called interoception. So your interoception is your body's ability to understand what's happening on the inside. So is my bladder full? Do I need to have a bowel movement? Does my tummy hurt? Am I hungry? Do I not feel good on the inside? So all of those pieces are what we call interoception. So with enteral feeding schedules, which is good. They're rigid, which is what they need to be. There's no comment on that at all. So we're not always giving the child time to be able to feel hunger. So, and sometimes some of our kids are on the enteral feeds for an extended period of time. So it's not a judgment on this piece. It's more just of a, hey, they may not show hunger right now because we're so timed with those feedings. So if we want to drive that hunger, we need to just think about that process a little bit more, and really starting to work when they're little on pairing some oral stimulation with those tube feedings, so we can understand all of those ways we get full. We get full through our mouth and we get full through our tubing. Okay. The fourth area of child factors that we examine are the child's processing skills, cognition, and language development. So feeding and eating are imitative skills, and they develop from primitive reflexes that integrate into functional patterns. For mealtime, part of this happens with the development of watching others during mealtime. As we discussed early with food vocabulary, we're priming the receptive skills to understand the food characteristics. Excuse me. So, and we're also looking for what the child does during play. So we're looking at whether they're imitating or whether they're tapping toys on the surface or together at mealtime. And this helps us imitate oral motor skills or holding a cup when we're ready. We're assessing visual skills and their visual attention to assist in improving attention to task. So, and down the road, visual memory of our food, as we just talked about. So, and we're also looking at executive functioning skills. Can the child sit down at the mealtime? Can they initiate mealtime? Can they get through mealtime and stop mealtime when they're ready? So, but working on all of these skills outside of mealtime is a great way to improve the skills without doing it during the pressure during mealtime, which is already likely to be a little stressful. A delay in motor skills can also, both fine and gross motor skills, can also impact feeding and eating. So not going to really talk about this slide much, but I really would encourage you, if you haven't already, if your therapist isn't already, to find a good positioning system for your child so that they can participate in mealtime, because even though their body may not be ready for it, their mouth might be ready for it and their mind might be ready for it. So getting children into a really good supportive position might enable them to really engage in that feeding process a little bit earlier. So our last factor that we're going to talk about is parent factors. So, or what we as adults bring to the table. So we're going to think about our routines and rules. So our routines are established sequence of events and provide structure to our kids. Some of us are great at routines. Some of us have more loosey-goosey routines. Some of us have really tight routines. No answer is wrong, but it's just that idea of how do you view a routine as a parent, and how is your therapist supporting you in what you naturally do as into your routine. We also have our rules or set of behaviors expected by society, shaped by culture and context. And really the word that we look at here is culture. Culturally, how am I supporting as a therapist what the family wants to engage in that feels meaningful to them? So what food is meaningful to them? What way do we feed is meaningful to them? We talk about our habits or specific automatic behaviors so that we do. So my husband is our cook in our family. And so, but I love roast the only way that my mom made it. It's kind of like a habit, not quite a habit. Dave likes to cut it up and serve it with tomatoes, which is just an astonishment. So as I'm making fun of him as he's sitting over there, but I like roast one way. That is my ritual because that's how my grandma made it and that's how my mom made it. And my mom's a really good cook. So, but what does that look like for us? How do we make those different pieces? Or how do we pull all those pieces in when we're talking to parents? And the last one is rituals or symbolic actions with cultural social meaning. So we can talk about those pieces too, but I often ask families, what's important to you during mealtime? What are the places that you really want to see your kiddo eat? What foods do you really want to see them consume? So that's what we're looking at. All right, so that's all of our factors. So we're going to talk a little bit about Mr. Jack here, and who is the cutest bug, right? I mean, seriously, he's just the cutest bug. So Jack is 5, almost 6, as Maureen said. So I'm going to briefly go over his medical because I'm sure Maureen can do a much better job, Maureen and Matt, on describing his medical history. But he had a G2 placement before he was discharged from the hospital. And he had significant GI issues with vomiting and bowel movement issues. And at some point in time, he had Botox to his stomach. And that significantly helped with processing of food through the digestive system. And vomiting didn't stop, but significantly slowed down, right? Is that right? Okay. Oral motor. So when Jack was little, he would place teeter toys towards his mouth, just right at the very front. And he liked to lick items. The one thing he really liked was a Mickey Mouse V-Vibe head that he would hold right in the middle of his mouth and he would bite on quite a bit. And he would not manage his saliva during that moment. So he really liked that. And he really liked water on it. And he also liked one type of jelly smeared very thinly on there. Those were the two things. And we tried all sorts of things. So, because he was interested in liquids. So Matt and I once tried a can of Coke. And we thought for sure he would go for that with all the fizz and everything. Nope, didn't want that. So he really would not put anything in his mouth posteriorly. But Jack loved water and still does love water. And he loved to play at his sensory bin with water. So we started putting animals in just for play. Well, he started picking up all the animals and licking them off. So we were like, haha, here's our way in, right? So over time, we started altering the water temperature. So we did warm water, we did cold water, we did a little bit warmer water. So nothing hot, but just a little bit warmer. And then we started introducing one small juice box. I love the moaning when they're going to sleep, right? It's so sweet. One small juice box into a huge sensory bin just to slightly change the taste of the water. So once he tolerated that, we did a few more, and then we did a few more. So eventually we took water to the table with a bowl and spoon. And I might be missing some steps in there, but I think that's about right. Yeah, along the way. So then we moved to clear chicken broth. So in a bowl so that Jack would eat that. And then eventually we moved to, and this is the part I was a little fuzzy. I can't remember how we did it, but we ended up moving to thin yogurts and like Danimals. And Jack enjoyed that flavor and then started to become really confident in exploring foods. And he would lick chips and Oreo cookies. That was his favorite. Pretzel rods, all sorts of things. We then started with crumbing graham crackers or Cheetos or cinnamon graham crackers or chocolate graham crackers. So crumbing it until they were just defined like almost like a graham cracker crust. And Jack would dip that in and he would start to lick that off of his fingers. So he was starting to get a little bit of some texture. And then we were able to start to put small crumbs of that over the lateral surfaces of his molars. So then his tongue was starting to move and he was starting to chew a little bit. We eventually moved to Cheeto crumbs. And in May of 2024, because I have it written down, Jack took a bite. Holy moly. I think Maureen and I cried because we were like, and I remember saying to you, I didn't know he was going to do that. And he did it. So that was when our door really opened up for Jack. So we changed from a sensory component or sensory skill deficit or sensory skill approach, I should say, to oral motor. So we really hit oral motor really hard for Jack. So Jack now eats, it makes me want to cry because he's done so well, eats a variety of foods. He eats soft foods, soft mixed textures. He's recently tried softer meats like chicken nuggets. He ate pancakes. He's eaten waffles. He's eaten grilled cheese. I can't remember. I mean, he's like a kid that's just exploded, right? So he's done so well. So I'm really worried that he's going to snag the other kids at school's lunches. I don't know that Marina and Matt are really worried about that, but I'm really worried about it. Jack loves pie. Oh my God, the kid loves pie. Pumpkin and cheesecake. Cannot get enough, especially with whipped cream. So now we're working on volume. We're continuing to work on variety and continuing to work on oral liquid intake. So we've talked about medical, we've talked about oral motor, we've talked about oral sensory, so child factors. So Jack took a long time to trust mealtime. And once the vomiting was not so prevalent, he tolerated more. But we still work on, because I see him for fine motor as well, we still work on visual scanning and attention span, keeping our eyes on our tasks. So self-regulation strategies and then sensory processing during sensory as well. And I will say with parent factors, I cannot praise Maureen and Matt and grandparents enough because they followed through a routine that was consistent across all caregivers. Parents and grandparents spent a lot of time working with Jack. So, and giving him lots of opportunities to try a variety of different foods. They've done a wonderful job. So, but Jack has consistent expectation across all environments so that he is in, which has really led to him just being now he's a good eater. He's a really good eater. So that is my presentation. Does anybody have any questions? No. Sorry, I hope I didn't. No, you're perfect.
I actually had one.
Yeah.
So when you were talking about gagging and humming,
Yeah.
can you explain that a little bit more?
Yeah. So when a child has a gag response, typically it's because the food, you can hear me okay. I almost thought I put my glasses on so I could talk. It's like you turn down the radio so you can drive, right? So when food lands mid-blade of the tongue, so when it's not pushed over to the side with those lateral borders, that can sometimes elicit a gag. So it's really tricky, but sometimes you can really cue a kid to place that food over to the side and hold and just hum a little bit. And that just gives a little bit of vibratory input. In the active gag, it's really hard to do, right? Yeah, because they're gagging and they're bringing it forward. Sometimes even us humming or us taking a big deep breath and making it very audible. So like a really big like that can sometimes cue that child because they'll start and turn and look, what's happening, what's going on? And that can sometimes stop the gag too. But even just that tickle in your throat or things that you think are probably coming up to be a gag, sometimes if you stop it with that hum, then they can get beyond and around that gag and continue to move. So, yeah.
Thank you.
Yeah.
Does anyone else have any questions? Oh.
Okay, I don't know if this is pertinent, I guess me and my mom are going back. AJ initially had GERD as a child and also right before, heart surgery had problems eating because of bleeding, but now we have the opposite problem.
He's eating a lot?
Too much.
Too much?
So we're just trying to find
Yeah.
ways, and I know this might be more mental than physical, ways to stop or curtail from just it won't stop.
Yeah.
Keep filling your life, not even if just stomach is still full, we'll keep on eating and
Yeah.
won't stop.
Yeah.
So
So during mealtime or randomly finding food?
randomly finding,
Oh, okay. Okay.
and sometimes other people.
Oh, sure. Sure. Yeah.
This is why we're
Yeah.
trying to stop.
It becomes an issue, right? Yeah. Yeah. Well, if it makes you feel good, there's better. There are many parents that struggle with that. And so as they, walking through the restaurant, making sure that the hands are to the side so we don't grab other people's food, right? As we're walking out the door. So I think a couple things that I would think about, and you as a parent and grandparent have to decide if this is okay for you. But I would think about locking the cabinet so that he doesn't have access to it, because long-term health implications can be significant, right? So we need to look at that piece of it. I think the other piece is do you work with an occupational therapist currently? Okay, so I would go back to your OT and I would talk to them about other sensory processing needs, because that crunch, that pickup, that hold, that want to put in the mouth might be able to be substituted with something else, some different types of sensory information that maybe the child is really craving instead of just putting something in their mouth.
Yeah.
The other thing I would think about too is boredom. Is sometimes we eat out of boredom because we don't know what else to do. So think about other ways that maybe his mind can be challenged a little bit more, and maybe some other things that he might be interested in. So I would think about those. That doesn't solve all your problems, right? So, but I would definitely think about, I feel as a parent, if I was in your situation, I think locking the cabinet is okay, or having some specific snacks that are put out every day. And when those snacks are done, then they're gone. And sometimes I've done that with kids that love a certain type of food. One of my kids loved chocolate pudding. So we had 4 pictures of chocolate pudding on a board, and he could have all 4 at once. He could have 4 at 1 at 8, 1 at noon, 1 at dinner, 1 before bed. That was his choice, but he could only have 4. So that was a way to limit, but give him independence. Does that make sense?
No, it does.
Yeah. But my gut, as an OT, I would really look at other sensory processing pieces, because I'm just wondering if there's something else that he really needs and he's substituting with it with oral stimulation. So I would think about that. Does that help?
No, it definitely does, because
Yeah.
I know for me, I switched out all the snacks for fruit and like instead of chips, we do
Yeah.
TV.
Uh-huh.
So it's a lot easier to get that same crunch and it's
Yeah.
not as much calories.
Yeah,
It's
perfect.
just, working with grandma and snacks are back.
I know. It's super. Oh, grandma. Oh, so grandma's involved. I don't know about that then. I don't know. I don't know. Usually what grandma says goes, so I don't know. Yeah, but you think about that. Yeah. You're welcome.
Are there strategies to help a child that refuses to take medicine?
Ooh, that's tricky.
Like, it doesn't matter, I don't know if it's mental or physiological with her, but it
Yeah.
doesn't matter if it's dissolvable, liquid, pill, like what it is, it's like total refusal.
So she tastes it in the medicine or in the
And
whatever
I
food
can't
it's
hide
in.
it, anything, it's like she knows
She
it's
can
in
know.
anything.
She knows that it's in.
She can taste it.
Yeah. Is it, so it's pill, liquid, any of them. She just doesn't want to taste it. Yeah. So one thing that you might try, and I worked a lot on pill swallowing, which tends to actually work really well for kiddos that don't want to take medicine because it's faster and you don't taste it. So that might be one thing that I would work on with your therapist. So is work on pill swallowing. So for that standpoint, I wonder a little bit about practicing with, most medicines are in droppers. So I wonder about practicing with juices that are the same flavor as your medicine. So she gets used to the squirt of that off to the side, but in something that maybe she would trust a little bit more versus the juice, versus the medicine. I don't know if you've tried that or not, so that might be something to try. So yeah, have you tried that or no?
No, and it is, it's like if you give her a syringe, just like immediately, like her tongue wants to spit it out.
Sure.
And
Yeah.
then, but those are good ideas. We can.
Yeah,
talk
just to try,
OT
to
about
try
it.
that piece. Yeah.
Yeah.
How old is your daughter?
She's 9.
9?
Yeah.
Okay.
And this is like going on 3
Oh,
years.
goodness, 3 years.
So,
Yeah. The syringes are hard because it's super inconsistent. The one thing that I find versus like the medicine syringes that I feel like are a little bit harder, you can get them through Amazon. They're a clear pipette, and they're made of silicone or they're made of like a clear plastic. But then you can pull up the liquid and it doesn't shoot. So you can control the squeeze of the top of the pipette in order to put that in the mouth without a big push.
Yeah.
Does that make sense?
Yes.
Yeah. So that's honestly, if you're going to do the juice idea, that's what I would use instead, because that might go a little bit better than that surprise. So you're welcome.
Okay, anyone else?
Well, if you think of any questions, my email is on the last of the slides and I'm gonna send them over to Lindsay so she can add them to your Google Drive with all the other slides. I do not mind answering questions at all, so please send them over. And if that strategy does not work or that strategy doesn't work, email me again and say, hey, I need more help, and I'm happy to answer a few questions here and there. So, yeah, thank you for your time. Appreciate it.